Thank you. Sorry, just unmuting myself. Let me just check too to see if my team made it on. Dave and Josh. Let me see. They were missing the link, so I need to see if they're able to.
Johnston is on.
Okay, great. So today, today's presentation will be fairly informal, but we wanted to share with the group how we get a lot of questions about deaths and death reporting, and specifically how that pertains to long-term care settings. So I wanted to share some of the behind the scenes on that and how death reporting works for COVID-19. In the state of Hawaii, a lot of it is based on national guidance or precedents set through state, the Council of State and Territorial Epidemiologists. So I wanted to start by just pointing people to where we house some of our data on deaths within our dashboards. Will I be able to share my screen?
Yes, go ahead.
Okay, great. Let's see, is that visible?
Not
yet.
Not yet.
Oh, here, I have not selected it yet. Can you see my screen now?
Yes, we can, Dr. Campbell.
Okay, so our dashboard visualizations provide some different ways of looking at the COVID-19 data. As you see with the tabs across the top, we have some maps that show where cases have been in the last 28 days or cumulatively since the onset of the epidemic. We have epi curves showing the cases that have been diagnosed by their symptom onset date or specimen collection date. Curves to show case rates by county, lab testing data that informs on number of tests performed and what % of those have been positive. And then we have age and gender and age trends and some data on race. So the data that we put out on deaths on these visualizations are primarily housed here under the age and gender tab. And we show by age category the number of hospitalizations and deaths within each age group. So what you see as a general trend is the outcomes are more severe among older populations, and that's well known. So of course, this applies to our long-term care populations. So we have seen hospitalization, for the composite outcome of hospitalization or death, we have seen rates of anywhere from 40% for that 70 to 79 year age group up to 59% for those 80 years and older. We also have some data broken out on deaths by race, which is under the race tab. When you view it as a table, we have posted the groups that have had at least 5 deaths. We have specific numbers to show what populations are most impacted right now in terms of deaths. So these are resources that I can share back with the group. I don't know if Josh or Dave is able to put the link in the chat to this dashboard. So if anyone wants to follow these trends over time, these are updated every Friday.
Yeah, I can put the link to the dashboard.
Great, thank you. Did Josh make it on, Dave, or is it just you today?
I'm not sure.
Okay.
I'm working from home, so I think he was on the email with invites.
Okay, so in terms of how deaths are classified, there are, the tradition in infectious disease reporting, communicable disease reporting, is that we look at deaths that are related to the illness that's being reported. And so it's usually a determination based on review of records or the case investigation itself to see, was the death likely an outcome of the infectious disease that was reported. For COVID, COVID has presented a number of new challenges in this domain. In some jurisdictions like New York City early on, there was such a high volume of cases and deaths that the jurisdictions could not always keep up with actually reviewing records. And so there were times at which deaths were reported out. If there was anything that came in on the death certificate, even plus or minus a known test result, that's added as a probable case. Thankfully in Hawaii, we haven't had to rely on that probable case definition for death reporting because we've had the ability to follow up for each of our deaths, what records exist. And we've had fairly widely available testing. So we also are more likely to hear about a death first where there is a positive COVID result associated with it, and then make the determination as to whether that death appeared to be related to the COVID positive test or not. We actually hinge that to the death certificate information, which is not immediately available. So what does tend to happen is that we may hear about a death and we know that the person had a positive COVID test, but it may take us some days and sometimes even weeks to get the final confirmation of whether COVID-19 was listed as either a primary or secondary cause of death on the death certificate. So Dave Johnston has been involved in cleaning a lot of our data on deaths. And, Dave, do you need me to present your slides, or do you have them and want to share your own screen?
I can present them. I've got them here. Let me see if I can figure out how to share them on here.
Oh, here. I think I have. Can you see them? I think I have that up now. Or are they still
I still see
screen?
the dashboard.
Okay.
Yeah.
I'll stop share and let you.
Oh, there we go, share screen. Sorry, I'm not too familiar with Zoom. So, okay, can you guys see the PowerPoint slide?
Yes.
Okay, so this is just a kind of a quick overview of the deaths that we do have reported, the confirmed deaths, as Sarah mentioned. We get reports of deaths in patients that may or may not have had COVID positive results, or even if they are confirmed cases that we know about, we don't know right away if the death was contributed to by COVID-19 or if it was completely unrelated. So there's a whole process that we go through to confirm those deaths to make sure that they are related to COVID-19, and then those ones are confirmed, and that's what's included in our counts. And so that process, as Dr. Kimball mentioned, can take quite a while. Sometimes if we are able to get in touch with the attending physician right away, we can get a confirmation from them that the death is related to COVID, and that that's going to be on the death certificate, or they're willing to sign that. That's one option. We also, if we're not able to get that, there's the death certificate or the death summary from the hospital or from the ME's office that we can also use to confirm these deaths. But again, those can take a while. If it's a medical examiner case, it can take weeks or months before we can get that confirmation. And so there's always going to be a lag in the numbers of confirmed deaths that we're reporting out and what might be reported in the media or things like that, because in the news, as soon as they get word of a death in a COVID case or something, they can count that, and it doesn't go through the same kind of confirmation that we go through. So that might be why you hear deaths that aren't included in our counts yet. But that being said, I've just got a quick summary of the deaths that we do have reported. So these are data as of today, but as usual with the caveat that these data we're in the middle of the pandemic response and everything. So these data are preliminary and they're subject to change as we gather more information. But so total, we've had we report out 103 deaths. One of those deaths was in a out-of-state resident, and so I've excluded that from this count. So it's 102 total in state. Looking at all of these, there's the median age range, or the median age was 75 years, and with the range from 35 to 98. So in an older population, there haven't been any pediatric deaths reported or confirmed. Out of all these cases, there are 65% of them are male. And then they're kind of spread out between Honolulu, Maui, and Hawaii County, with the vast majority of them being in Honolulu, with almost 90% of them there. Now, currently there are 32 deaths that are pending confirmation. So these are not included in this 102. So those are the ones that we've received reports of, and that we're following up with the clinicians, or trying to get the death certificates. And as we get those confirmed, then these will be included in our counts, or not included if it turns out they are not COVID related. Now, of interest to this group particularly, we broke it out into, well, I use the term healthcare facility, but that's a little bit of a misnomer. This is more focused on the long-term care facilities, as opposed to, this is not including cases that died in hospitals in the healthcare group. So it's basically a long-term care facility. You can see the list down at the bottom of the ones that the types of facilities that are included. But so I broke this out into comparing the non-healthcare facility deaths to the healthcare facility deaths. And in total, we've had 14 cases reported, deaths reported from healthcare facilities have been confirmed. As might be expected, the age range seems a little higher, as a median of 91 compared to median of 72 for the non-healthcare facility deaths, and with a little bit higher of a range as well. The gender or sex, however, is pretty much the same. Both have 65% male. And then the spread between the counties, the majority of the healthcare facility ones have been reported from Honolulu, with a few in Hawaii. And then with the non-healthcare facility, it's been mostly Honolulu, with several in Maui as well. Breaking down the healthcare facility types, or the deaths into the different types, we've had half of them been in skilled nursing facilities. About a third of them have been in adult residential care homes, and then 20% have been in community care foster family homes.
Although I will emphasize that there are many pending classification for some of these categories, so these numbers may change even in the next week. Yep. Thanks.
And then I just have a couple. This is the same data, just in a visual form, rather. This is looking at the deaths by sex, and the colors represent the healthcare facility deaths versus the non-healthcare facility. So there have been a majority of the deaths have been in males, but it's females are also included in there. And then looking at it by county, you can see the vast majority of them have been reported from Honolulu County, but Maui and Hawaii are both also represented in this, with Maui having only non-healthcare facility ones confirmed, and Hawaii just has the healthcare facility ones confirmed. And then looking at the ages between healthcare facility cases or deaths and non-healthcare facility deaths, you can kind of see it makes the difference a little more apparent. The healthcare facilities definitely are ranging a bit older than the non-healthcare facility cases. And that's just the basic summary that I have. I don't know if there's anything that Dr. Campbell wants me to add, or.
So I think we may not have managed to catch Josh today, but what I was going to have him speak about is a little bit more on the death registry system and how that links up with our COVID surveillance. And that is still something that we are working on, a more direct linkage. So right now, when we become aware of a death, or death registry gets a report that meets a criteria for possible COVID-related death, then we are manually exchanging that information periodically so that we can cross-reference our lists and update them. If you were to go to the National Center for, I'm blanking on the acronym, the NC, I have lost it. The vital statistics all get fed into a national repository. that will show you death rates by state and county as well. And we often do notice there's a difference between what they'll post there for Hawaii and what we have. And often it seems the vital statistics data lags behind ours to some degree. And that has to do with the timing of submitting those reports and when they get posted to those CDC websites. So the death registries are based on what's filled out on death certificates. We're of course getting case data where we hear about results of testing in a person that was already being followed for COVID, potentially as a contact or newly identified as a case. And our job is to try to match those up and see where they meet in the middle. The death reporting process hence is a fairly slow one, but it is important for us to understand what the overall burden of disease we're seeing for COVID is and what the outcomes are. So that concludes the information that we were going to share on deaths. I know there may be questions from the nursing homes about death reporting or perhaps questions related to NHSN. So I'd like to open the floor up for questions and comments.
Thank you, Dr. Campbell. I'm just looking at the chat box. Thanks, Dr. Johnston, for giving the link to the dashboard. If anybody wants that link, please get it off his chat. There are a few questions already. The first question is all the point of care testing that the nursing homes are doing going to be added into the numbers?
So right now, what we've started to do on our website is to include a table updated each Friday with probable cases. In the new case definition that was released by CSTE about a month ago, there is antigen testing is now included as a probable laboratory criteria. So if you have a positive antigen test without confirmatory testing, that puts you into the probable case category. So in that sense, yes, point of care testing with a positive result from an antigen test would get included as a case. However, we also have to hear about it in order to get included on our website. One of the challenges with antigen testing is that it's not linked in the way that the NP swab PCR tests are through a CLIA certified lab. And most of the laboratories in Hawaii are sending data electronically to the health department in real time. And that's how we get the case information for through those electronic laboratory reports. With point of care testing, we're much more reliant on the provider informing us of the result. So the announcement from CMS about the requirement to report all the point of care tests to the health department was relatively recent and also unexpected for us. So one of the things we've been working on as a system is developing better systems to receive that data in a standardized format. I should actually have had Nia on because she's the one who's primarily processing the results that people are sending right now. And I think that the current system is sending that by fax or by email to her through the HAI inbox. So that's how we're currently getting those reports for those who are reporting, and thank you if you have. We will have more information to come soon on a standardized method for reporting, and we're trying to build an electronic system that allows that to happen more easily.
Hi, Sarah, I'm here.
Oh, great. Nia, did you have anything to add on current status for reporting of results?
Well, right now, yes, they are sending us some line lists. It's not a standardized line list, but that's what we're working on developing. I send the facilities a line list with the variables that we need for the data to be transferred into our
surveillance system.
Surveillance system. But then that might need to be modified just a little bit depending on
so
the
this is an
feedback that we're
area
getting.
where we're definitely building the plane as we fly it. So bear with us, but we will have more information to come on best methods for reporting those point of care results. In the meantime, the biggest take home point is if you have a positive on point of care testing, pick up the phone and call the disease reporting line because we would not necessarily know about your positive result unless you tell us.
Thank you, Dr. Campbell, and thank you, Nia. The next two questions are related, and I had the same question. What are non-healthcare facilities, and does that mean that 88 people died at home? I was surprised by that number too.
No, this
no,
is
so-
just a group of people who weren't associated with a healthcare cluster. So not associated with a long-term care setting. So there are many people who die in hospital. This isn't a division. What Dave showed is not a division of died in home or died in hospital. It's based on the setting of exposure.
Okay, okay. Thank you for clarifying that. I think I thought the same thing. I thought that was the place of
Thank
death.
you. We'll be sure to clarify that on future presentations.
So for our audience, the two categories were just where the disease was contracted, I guess. So when it says non-healthcare facilities, it means it was a community-acquired COVID compared to the others, correct?
Right.
Okay. The next question is, are all the Hilo VA facility deaths in the 32 pending confirmation number?
Right now, we still only have 3 officially reported as confirmed from that facility, but I am aware that there are others that I think we just got info back on today. So we will be updating those counts with tomorrow's report.
Thank you. The next question is, would you please define the death registry?
Yes, sorry, I did not do that justice, and I wish I had Josh on to explain better. But this is the vital statistics reporting process. So just like when you're born, you get a birth certificate, and that goes into a birth registry. When you die, the death certificate is signed, and that goes into a death registry, and that all feeds into national reporting systems as well. So there's a national death registry for which I was having trouble recalling the acronym, but
the National Death Index, NDI.
Yes, thank you. So that's derived from the National Death Registry reporting. So that's what I'm referring to in terms of the death registry. So our Office of Vital Statistics is the part of the Department of Health that deals with death reporting. So our work around COVID has been a collaboration with them.
Thank you, Dr. Campbell. The next question is, actually it's more a comment, but hoping that all the negative antigen tests will help us bring down the % positivity rate. Could you comment on that, please?
Yeah, I think % positivity is, it's a really interesting metric to follow. It also has a lot of different factors that feed into it, so it can be a little bit hard to interpret sometimes what that means. % positivity is a reflection in general of, you know, well, in the most basic sense, it's the % of all the tests that you're doing that are coming back positive. But what determines that is not just your actual disease activity in the community, but also who are you testing, where are you testing, and how much are you testing. So I think what we've seen in the recent downward trends with % positivity, there's 2 factors at play. One is the surge testing, the federal surge testing that has been going on over the last couple of weeks. The surge tests have had quite a low % positivity rate if you look at those alone, under 1%. And so that's brought down our overall % positivity. But even if we remove those from the equation, which we've looked at, our general % positivity has also been trending gradually down over the last couple of weeks. And that may be, it may be soon enough to be seeing some impact of the stay-at-home order, so that may be part of it. There are many other factors that drive the epidemic curve, just in terms of people's response to the communication messages, how well people are implementing social distancing, and what things are open and happening in the community. The % positivity, though, can be altered if you test in a low-risk population. It could be lower than reflecting the actual disease activity population-wide. And vice versa, if we're doing a lot of testing that's very targeted and directed by our outbreak investigations, that can also really drive the % positivity up. And this is more true in Hawaii than in some larger jurisdictions where this will be more evened out. So for that reason, we tend to place a little more emphasis on the actual population-based case rates, which are not going to be as subject to the differences in who you decided to test on that day.
Sarah, this is Nicole Apoliona from Maui. Did you say that the surge testing is included in the total test
What you
numbers.
see on our dashboards is including the surge testing. And for most of last week, that made up, I'd say, about half of all testing that was happening in the state. However, if you remove it and you look at the percent positivity without that, we still see a downward trend in percent positivity, and we still see close to 5,000 tests a day without the surge testing. So I still am reassured that our overall percent positivity is actually heading down, even though the surge testing may have been looking at a slightly different population than the targeted testing that's otherwise happening. So it is reassuring in the sense that, you know, we went out and tested a bunch of people who maybe wouldn't have otherwise thought to get tested. Well, if 10% of those had come back positive, we would have had a nasty surprise and had to say, well, wow, this is a lot worse than we realized. But instead, seeing that less than 1% of those people are positive means most of those people walking around that you know, if you are going to work because you're in an occupation that still goes to work, it's not true that most of them are walking around positive unbeknownst to you. So I think it's reassuring in that sense.
Thank you, Dr. Campbell. I don't see any other questions in the chat box. Does anyone else have questions? You can either put it in the chat box or just speak up if you want to. You can unmute.
I'm sorry, I joined a little bit late, but did you talk about actually completing the death certificate?
That's a good point. I probably should have arranged to have someone from our Vital Stats division come, because they have provided trainings on completing death certificates in the past. I know Josh actually has some links to the videos that they've put out in the past on training for completing death certificates, but that's a really important point. The way that we are classifying deaths really does have a lot to do with how physicians are filling out the death certificate. So it is important, and it does require some thought as people decide how they're going to fill out that form.
Dr. Campbell, I'm aware of that the Hawaii Department of Health puts out for that. And actually, I use that to train our fellows every year before they graduate.
Yes.
I don't have the link readily available, but I can give it to Michaela later to make available to the audience.
That would be great. And just a side story to that, last year we had seen, we had noted, because of actually a national news media story, that Hawaii had the highest rate of pneumonia and influenza deaths in the nation. And we thought that was very odd, because when we do track influenza and pneumonia and influenza mortality through our flu surveillance program, and we were not seeing that trend. We scratched our head for a while wondering if that was something wrong with our baselines. But when we actually decided to do a data poll in collaboration with Vital Records and look at the actual certificates to see what was going on, we realized that it was just a small number of physicians that were interpreting the death certificate in a certain way. It was really a kind of a user training issue that was substantially contributing to that increased mortality rate. And once we corrected that by educating the physicians and doing another estimate, removing those particular outliers from the trend, we saw that we actually had a much more middle of the road to low pneumonia and influenza mortality rate. So it's an important story about the importance of that death certificate completion process.
Thank you, Dr. Campbell. So just to confirm, if somebody dies of pneumonia related to COVID-19, the underlying cause of death should be coded as COVID-19, correct?
Say that one more time for me.
If somebody has pneumonia because of COVID-19 and then they die, then the underlying cause of death should be the COVID-19, correct? Not pneumonia, but COVID-19, so that it's caught.
We will count, and I'm not an expert on the training on death certificates, so I don't want to speak to how exactly you decide on primary versus contributing cause of death, but we will look at anything. If COVID-19 is written as any cause of death on the death certificate, it gets included. So it does not have to be the primary cause of death. It could be underlying or contributing.
Got it. Thank you. The next question is, do you know how many people in Hawaii have died at home?
We probably could pull those numbers. I don't have them off the top of my head. We have seen people die at home. So that does happen. Some of the circumstances of that are related to wishes of the patient, though. So I am certainly aware of a number of deaths at home where the patient did not wish to be hospitalized, had a DNR order. And so some of that is happening in that type of context or in a palliative care context.
I'm actually aware of the hospices being involved with patients who've died at home. And in fact, this evening, Kokua Mau is having the palliative poo-poos. And I believe the topic is COVID hospice patients. So I believe that's the topic for this evening's palliative poo-poos. The next question is, if our lab is reporting the positive cases, do we still need to call into the reporting line or just fax the forms to you?
We definitely need the faxed forms. Technically, COVID-19 is urgently reportable, so it's supposed to be phoned in. In all honesty, we are working madly to have a better web-based reporting system because during a surge like our recent one, it has not been possible to keep the phone lines open to make that a reasonable expectation. I guess our fear is missing a report, and so trying to make sure there's some confirmation, at least in a batch format, that your reports are getting through.
Thank you. The next question is, how are doctors trained to complete death certificates?
Yeah, like as we were referring to, there's a video that Vital Statistics, our Department of Vital Statistics had put out to train physicians and other providers on completing the death certificates. We also reviewed that and sent it out again after that pneumonia and influenza investigation that we had done last year. So I think we will, it sounds like you can put that in the chat afterwards, and that's a good resource.
Unfortunately, in my experience, physicians are not trained to fill out death certificates. That's why when I found out about this Department of Health with the web-based training, I was so impressed by it actually, because for the first time we had something that we could use to train our fellows. Mm-hmm. So I've been using it every year since I found out about it a long time ago. But when I was a resident, I was not trained. I was trained by my upper level resident, basically telling me their opinion, which is not really training. So I think
that was my experience as well in residency. I have to say, I think it's not an area that training programs have historically put a lot of emphasis into.
I think we need to do a better job. Mm-hmm. Okay, the next question is, if COVID is listed as part 2, other significant conditions contributed to death, is that counted as a COVID death?
Yes, it's counted as a COVID-related death, and that's what we're basically tracking on the website.
Thank you. I don't see any other questions in the chat box. If anyone has any, maybe you'll give them a minute or two. In the meantime, I'll give a couple of reminders. In order to receive either CMEs or a certificate of attendance, you must fill out an evaluation. The evaluations are found by following the link in the chat box or in the invitation or by going on our website. So please do that so you can get your credits. The next session that's going to be scheduled is on Wednesday, October the 21st. I don't think there's a topic yet, but I'm sure it will be sent as soon as we get it. Oh, and Jeanette is on. Oh, thank you, Jeanette. Jeanette sent the registration link in the chat box for the palliative poo-poos tonight. This is clinical case discussion, and I know that tonight they're talking about some hospice patients with COVID. It starts at 5:15 p.m. tonight. Thank you, Jeanette. It sounds like that's all our questions. Oh, 2 hospices are reporting on their COVID experiences tonight. Well, thank you all very much for attending, and a special thanks to our speakers, Dr. Campbell and Dr. Johnston, for a very interesting and informative presentation. We hope to see you all next month at the next session.
Thank you for having us.
Everyone. Bye-bye.
Thank you.